we're going to spend some time talking about the heart and the circulatory system. And I want to center this discussion originally around the determinants of your blood pressure. So your blood pressure is equal to your cardiac output times your systemic vascular resistance. This is your standard pressure equals flow times resistance type of formula. Then your cardiac output is your heart rate times your stroke volume. So the amount of blood that's actually ejected for every beat times your heart rate will give you a cardiac output in mils or liters per minute. We can further break down stroke volume into its determinants. The stroke volume is equal to what is in the heart at the end of its filling, so end diastole, or end diastolic volume, minus what's left in the heart after it's done ejecting, so end of systole, or end systolic volume. If there was 90 mils in your left ventricle at the end of diastole and only 20 mils left in your left ventricle at the end of systole, that means you must have ejected 70 mils. So your stroke volume there would be 70. The volume of blood in the left ventricle at the end of diastole is your preload. Technically, preload refers to the actual stretch of the myofibrils, but we could say that the left ventricular end diastolic volume or the left ventricular end diastolic pressure are both akin to the preload of that ventricle. And the compliance of the ventricle will affect how much it can actually fill during the diastolic period, so how much preload you have. And then your end diastolic volume is determined by your contractility and afterload. If these words don't mean much to you right now, that's okay. We'll kind of define them as we go here. What I'll show you here is the filling and emptying of the heart during the cardiac cycle and how preload, contractility, and afterload all affect your stroke volume. We'll choose this as our starting point. So this is point number 1, where your mitral valve opens. This allows filling of the left ventricle from the left atrium, and the volume will increase as we go along the x-axis here. The pressure will slightly increase as well as we fill the left ventricle. At this point, the left ventricle will stop filling, marking the end of diastole and the closure of the mitral valve. So the volume here is our end diastolic volume, and the pressure here is our end diastolic pressure. This is now the beginning of systole, where you have isovolumetric contraction. So you see that your left ventricular volume is not changing, but your pressure is going up as you start squeezing down on this ventricle. Then at the endpoint of the isovolumetric contraction, we have opening of the aortic valve. So now we can start ejecting blood. So your LV will keep contracting, and then we'll see that the volume of the LV starts to lower down on the x-axis here. Once the pressure in the LV falls back to more or less the same pressure that opened the aortic valve, we'll have closure of the aortic valve, which means we're done with systole and we're going back into diastole, and we'll see our left ventricular pressure falling until the mitral valve opens up again and we start to refill the left ventricle. That being the typical filling and emptying of the left ventricle during the cardiac cycle, I'll show you how preload and contractility and afterload change that. Preload, as the name suggests, means that we have a greater amount of stretch of the left ventricle at the end of diastole. So we're going to end up with a larger end diastolic volume. So we're filling our ventricle here, and then with an increased preload, the ventricle will keep filling even more, and we'll have a higher end diastolic volume. So we can follow this up, and this won't change when our aortic valve opens. So we'll have that opening at the same time and closing at the same time. You can see by increasing our preload, the stroke volume, being your end diastolic volume minus your systolic volume, is increased. If you were to drop the preload by giving an induction dose of an anesthetic, for example, you'd have the opposite effect on your stroke volume. So instead of filling more, you would be filling, and then this is as much as you'd get. So your stroke volume here, your end diastolic volume minus your end systolic volume, is highly dependent on what our preload is. Afterload is the ventricular wall stress of the heart during systole. You can think of this as the amount of pressure that the heart has to overcome in order to start ejecting its blood, or for the aortic valve to actually open. So with a high afterload, you'll need to generate much higher pressures before your aortic valve opens and you start ejecting the blood here. And because you need a much higher pressure for this, the work that your myocardium is doing is higher, and there's more resistance to ejecting this blood. So you're not able to eject as much as if you had a lower afterload. So your end systolic volume will be higher because your stroke volume is relatively smaller when you have this high afterload. Lastly, we have the contractility, which is the ability of the myocardium to contract, and this is independent of the preload and the afterload. Another word for contractility is the inotropy, and that's how well the heart ejects blood given any amount of starting stretch of the myocardium. If you have two hearts, both with the same preload and same afterload, say this one ejects 70 mils, then we increase the inotropy of the other heart, it may be able to eject 80 mils, even though it has the same preload and same afterload. So the increased inotropy is an increased ability to contract at any given initial stretch. On this diagram, that would look like ejection occurring at the same time, but then for a larger amount of blood to be ejected, because the myocardium here is better at ejecting the blood with its higher contractility. And because of that, our stroke volume is increased because we've ejected a higher fraction of blood from this heart. Factors that affect the contractility of the heart are sympathetic nervous system inputs, specifically beta 1 receptors on the myocardium. Hypoxia decreases the contractility. Acidosis decreases contractility. If you have an area of ischemia or an infarct, that'll decrease your contractility, obviously. We have pharmacologic means of increasing contractility again. We call these the inotropes, and they'll increase your contractility. Typically, these are beta 1 agonists, again, acting on the beta 1 receptors of the myocardium. You could also give a beta blocker to decrease the contractility. And then calcium is worth mentioning, has a decent effect on contractility. And if you are hypocalcemic, you'll have decreased contractility. I think that's a good place to take a quick breather. And then in the next video, we'll go over preload and afterload.